Lincoln. The story is allegedly my father, your cousin, wanted to go to Lincoln, but my grandfather told him he couldn't go to an HBCU because they do too much partying. But
they do party at Lincoln.
What you described, and I don't think it gets talked about enough, is that growing up in Black America, especially when you go on to get educated, or maybe even just in the neighborhood you grow up in or the school you go to, you're often judged and evaluated by your own people based upon how you talk and carry yourself. You know, the name of my blogging platform, Big Words, that the origin of that name was elementary school. And because we had books in the house and because we talked a certain way, some of the other kids of color in my elementary school, it's probably around middle school, asked me, why do you use those big words all the time? And I didn't really understand what they were asking me at that time. But as I got older, I realized that, you kind of have to find where you fit in. And at some point, you have to accept who you are and be okay with who you are. And just, not everyone is going to accept you. And there are different definitions and concepts of what Black is. And,
Right.
You have to be okay with who you are. That was a lifelong journey for me. And that's something that a lot of us have to navigate.
Right. Can I add that when I was in Marist College and I was a junior, we had a freshman that came from suburbia of either outside of Chicago. And he was also having a problem sort of fitting in with the other African American community. And he kept saying to me, I don't understand. And I said, I understand. I said, you have to realize, how were you raised? And he explained it. And I said, okay, you and I have sort of a similar raising. We were not raised in a predominantly Afro-American community. We were raised, and yes, I think he went to a private school for a while. No, I take it back. He went to public school. But the majority was people of non-color. And he was also introduced to the arts and everything else that was, yes, there was the Black arts and music, but he was also introduced to the other arts and musics, like I was from my community. So basically, he wasn't fitting in the way the people that were from a predominantly Black area, even if it was of the upper middle class Blacks, he wasn't fitting in with some of them either because of his raising. And as you said, he had to find himself, like I had to find myself, comfortable with who I was. And realizing that, you know what, one of my sayings has always been since that experience is, yes, I am of this color, but a lot of times I view myself as just being a human being.
Yep. Yeah. So culture matters, socioeconomics matters, all that matters in who we are, not just our skin color.
Correct.
So, and the values you were raised on, or raised with, those matter. Mm-hmm. Okay. So you went to Marist, and for medical school, you went to
New York Medical College.
Where's New York Medical College? Is that in Long Island or is that in the city?
No, it was originally, interestingly enough, it was a couple of blocks from where your father was raised.
Oh.
Okay, in East Harlem. It was the Flower Fifth Avenue Hospital. But then they moved up to Valhalla, New York, because I think it was Mount Sinai had also moved down to like 99th Street, and it was expanding, and Flower and Fifth could not expand. So they got their campus moved up to Valhalla, New York, which is in Westchester County, where they could do more of an expansion. And from there, I went to John F. Kennedy Medical Center. On match day, I got accepted to their residency program.
Okay.
I went there.
Okay.
And that was in Edison, New Jersey.
Edison, New Jersey. Okay. So, so Tommy, so when I interviewed Dr. Cedric Bright, he told me that his biggest challenge in medical school was the volume of information to, learn, process, integrate, and to, think about as a medical doctor. And he also had to, he had to learn how to assimilate and study with students who didn't look like him, peers who didn't look like him. What were your major challenges when you were in medical school? Did the volume, was that something you had to get used to? Was it long hours at night studying, or what was it?
It was a combination of the volume. I am not one of those people who can demonstrate that I have a photographic memory. So I remember having some of my friends, while I'm studying till like 8, 9 o'clock at night, this time of the year, or even in the fall when it's still light out at 7, 8 o'clock, they've already finished studying by 7. They're out playing basketball, or they're out jogging and running. Here I had to basically be dealing with the books the most I could. So that volume and trying to study was what was my major problem. Because you gotta realize back then, the first 2 years were academic. You didn't get your clinical until the second 2 years. But now they mix clinical along with academics. So here we had all that pushing in of biochemistry, physics, anatomy, etc. So that was the difference.
Okay. Was there anything that helped you process that volume, or was there did you have to adjust your studying in any way, or?
I basically had to learn how to spend long hours up, trying to repeat things so that I could remember to myself what it was that was important. But as far as any specific tools that I developed, the only tools that I developed was you have to learn how to process the information. And the only way that you're going to process the information is by you studying hard and using whatever tools you can develop that's going to make you pass the test. Now, when it got to the clinical years, the nice part was application of what I was reading. In other words, running across kids that had ADHD, running across people that had congestive heart failure and trying to understand how the heart worked. Across those that had diabetes or asthma, and taking the application, what was said in the books as symptoms and symptomology and how to treat them, and then applying that from books to the cases to help reinforce.
Okay. What's your specialty? What did you get into?
Okay. As I said, I was at John F. Kennedy Medical Center in Edison, New Jersey, and my specialty there was family practice medicine. We basically ran the hospital. We were in charge of the ICU, which was about a 15-bed ICU. We did the rounds on the wards. We coordinated with different attendees on certain cases, and that's how we did our thing.
Okay. Okay. Now, I know that you've moved around a couple times. Have you done the same thing in every state, the same specialty? Have you opened up your own practice as you've
I
gone
never
along?
opened up my own practice, but it's always been family practice.
Okay.
Because family medicine gave me that big diversity. There was a time period when I was in medical school when I thought about becoming a radiologist because I really liked the intrigueness of trying to figure out what was on these black and white films. And then they came up with the CAT scan. They didn't even have MRIs back then. They were still developing it.
Mm-hmm.
So with that said, I realized that I basically was more of a people person and I had to be involved. And then, as I said to you initially, earlier in this interview, that I also wanted to teach. So I felt, you know what better way than being in family practice? You get to teach people how to take care of themselves, how to take care of their children, how to take care of themselves when they're pregnant, preventative care, and also chronic condition care, and teaching them. Okay, so that's why I went into family practice, and even my evolution through family practice over the 35 plus years, as I tell some of the mid-levels I've worked with and some of the students I have happened to have been their preceptors from medical school and from residency program. As you transition through medicine, there's something that's core that keeps you attached, but then you also have to find little venues or aspects of medicine that keeps you more intrigued to stay in medicine. So as I was explaining to someone earlier this year, I said to the mid-level, I said, yeah, when I started off, I got on my residency program, I was doing OB/GYN, and I was all excited because I was delivering babies, and I was having a great time, even though I would have to get up in the middle of the night. I got to deliver twins to a grandma tip. It was her 12th pregnancy, but she was having a set of twins, which puts that like a high risk. And, I got to do that. But then going from there, then I worked at an HMO, which sort of restricted our OB rounds and ability to do OB. And so what I got more interested in was actually just teaching people how to take care of themselves. And also one of my main loves, as I said, has also been promoting education and promoting young people to do the best that they can in school and to think about what they're going to do when they become adults, whether they're going to go to college, whether they're going to get a trade, but to make the most of themselves and fulfill their potential. So with that said, that's what's kept me in medicine, just finding these little venues. Now, right now, I've also been dealing with opioid addicted patients for the last 10 years through the MAT program, dealing with Suboxone. I've also been in more of an administrative role as a medical director, even though I'm a medical director now. I've had five positions as medical directors over those 30-something years, helping to guide the development of medicine for people. And what's interesting, as I told my medical advisor, when he asked me about my present position and where I'm at, I said, if you really look at my career, I've always worked in an underserved area, even when I worked for the HMO. I worked in their valley area, which had the janitors and maintenance people for the educational school system and the farmers. Before that time, I started off, I left my residency program. I went and I worked with Indian Health Service with my government obligation. And I worked in Sumter, South Carolina, where we were the only people accepting Medicaid. Then I went to the HMO where, as I said, I worked in the Farm Valley and everything else. Okay, migrant workers, etc., the farmers, the people who were like the maintenance staff, janitors, and not many school teachers. Then and that was in Albuquerque. And then when I went to northern New Mexico, I worked for a federally health qualified clinic, which I'm working for now, and that also involved me dealing with the underserved, the Medicaid population, at all.
Okay. So you're passionate about serving that demographic.
Yes. It only dawned on me, basically, as I said, when my medical advisor asked me, well, why are you going out to Louisiana to work? And I said, well, I have an opportunity to help be a medical director, which helps to drive care for the underserved. And when I looked over it all, it was like, yeah, this is what I want. Even when I was looking into leaving New Mexico after being there for like 30 years, I looked for other federally qualified health centers in like California, Utah, Oregon, and this sort of fell into my lap, and I was like, yep, that's where it should be.
Okay. Well, before we move on, just briefly, the difference for the layperson, the difference between family practice and owning your own practice or running your own practice, what's the difference?
There is no difference in running your own practice. You can be a family practitioner and run your own practice.
Okay.
I think what's the difference between a general practitioner and a family practitioner?
Yeah.
A general practitioner is someone who actually has done maybe 1 year of residency program and goes out and hangs their shingle. Okay. Family practice is a residency program where you actually spend 3 years learning a whole bunch of stuff. You sit down and you take the board, you become board certified, you have to become recertified and recertified and recertified, which at my tender age right now, I decided I wasn't going to do because I was expected to retire by now, but I'm loving medicine. So I didn't do my last recertification, but I still am keeping up with my CMEs and learning aspects, because once you're in medicine, it just becomes this innate that you want to learn more and more, and you might keep your skills up and be astute. So that's the difference between general practice and family practice when you're talking about that. Plus, you have to look at it this way. In family practice, you are trained in OBGYN, internal medicine, adolescence, and psych, to name a few of the disciplines.
Okay. Now, when I was an undergraduate at Johnson C. Smith University, I was in the general biology, the Department of Natural Sciences department, and a lot of students said they wanted to go to medical school, and obviously you need the GPA to get in. You need a competitive MCAT score. But what are the other things that you need for aspiring medical students? Is it an innate curiosity? Is it the compassion to want to help patients and treat disease? What are the intangibles that medical schools are looking for when they're separating candidates out, in your opinion?
In my opinion, and I'll tell you why I'm coming up with this later on in our conversation on the subject matter. In my opinion, it basically is that you've shown an innate desire to be involved with medicine, to do something for humanitarian, to do something humanitarian. And you've also done other things on your summer vacation or during your time period in in undergrad that shows that you are interested in the field of medicine. The reason I say that is I remember when I was at New York Medical College, we had a few people who were not in the sciences. One was in music, but she also did such things as she worked in a nursing home. She did some office work with a physician also. So there was this person who passed the MCAT, had a good GPA average, and at the same time period, she was involved in another aspect of medicine that wasn't backed by her having a bachelor's of science degree. I've had another, how can I say, nurse when I was working with the SQHC, and basically she initially was an English major, but then went to go into medicine. When she became a CNA, then she became a medical assistant. And instead of going into nursing, she wanted to go and become a physician. So she started taking some more biology classes and chem, PChem and all this other stuff that's required now, so that she would be eligible to be a candidate based upon that aspect of what the medical schools are requiring now compared to when I went in the 70s.
Okay. It is fascinating. Dr. Cedric Bright told me something similar, that he did not, ultimately as an undergraduate, he didn't major in a STEM. He majored in something else. I can't think of it right now. By the way, I'm going to leave those interviews with Dr. Capers and Dr. Bright in the description box below. But it is fascinating that you can major in something else, non-medicine, non-science related, and still ultimately take that career path. So we're almost at the end, Dr. Strain. How has medicine changed from when you first started to now in 2020? We have a lot of gadgets now, a lot of technology, a lot of wireless, toys and computers are involved in everything. How has it changed?
I'm just going to say this. When you look in the 70s, when I started out, basically medical school, we didn't have ways of truly diagnosing diabetes and saying you were in this category versus that category. Now we do have that technology. We didn't have MRIs. We didn't have some of the ultrasound, the 3D ultrasound. Better yet, we didn't even have, the CAT scan was a big thing back then as I was getting through my residency program. You did plain film. You didn't have many CAT scans during the residency program. And then they got the CAT scan. Then they got the MRI. Now they've got like these 3D imaging CAT scans that does that. The other aspect, which some of us old timers are still having a problem with, is the electrical medical records and data gathering that's going on. Okay, electric medical records or electric health records has a plus minus. The plus is, yes, it helps get everything electronically. You can transfer files if you want to. The minus is that not every system reads the other person's EHR. So unless you're in the same facility or same organization and you all have the same EHR, you can't data share the way or record share the way it should be. I think that's what the initial was. But being who I am, in a capitalistic world, as someone said to me, did you expect them to be like China where they all have the same EHR? No, we're in a capitalist world. Everyone needs to make some money. So therefore, you've got the Athena, you've got the ECW, you've got the there's like maybe 5 or 6 or even more, but they all have plus or minus, and unless your organization has the same, it's not going to work. Now, luckily, talking about this situation, what's been nice is we used to not have the ability to fax medical records over to people or put them on discs. Okay, now we have that availability. So basically, in fact, basically, if you, let's say there's a system where I know all the specialists in my group and they have the fax capacity to accept records, I can I can download my EHR information on a request referral sheet and then send all that via fax over to them so that when the specialist sees you, they have all the information that I have, including my notes, any laboratory tests I've done, any X-radiological evaluations I've done. And as I said earlier, I didn't know about interventional radiology, or I might have been an interventional radiologist because it wasn't available at the time.
Okay.
Okay.
Okay. So there are some aspects that the technology is either driving or makes available.
So much.
Yeah.
You think about robotics for surgery. We didn't have robotics for surgery when I was there, and that's become the biggest thing. You know, robotics for doing abdominal surgery, robotics for doing shoulder replacement, hip replacements. There's robotics for also doing some of these neurosurgical procedures. So yes.
Okay. So two more before.
Add this. Can I add one thing?
Sure.
I just want your people to know that also. I used to stutter until I was like 13, 14 years of age. I still stutter on and off. Mm-hmm. And because of my stuttering, I also had what someone told me one time period, you're a little dyslexic. And I said, and you know, you deal with
okay.
what
all
you're
right.
given.